I guess with that, we will go ahead and get started. Good afternoon, good morning, and good evening, depending on where folks are chiming in from different parts of the globe. I'm Alain Labrique, a professor and associate chair for research for the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. I'm one of the co-organizers of this fantastic event and this day. It's really my great privilege to be working closely with the Center for Global Health and our colleagues from across our department, school, and partners globally to host this afternoon session of Global Health Day 2021. It's a pleasure to have so many people joining us for Global Health Day from around the world at a time when we're all stretched so thinly across many demands and responsibilities. Many folks here, including Megan, Anna, Tom, Smisha, and so many others have worked very hard to pull together an exciting morning session, which some of you are coming out of, and now this afternoon session, which we hope you will all find intellectually rewarding and, if successful, thought-provoking. As Tom Quinn said this morning at the launch of Global Health Day, this is an annual we're very proud of that showcases work done by students, faculty, and collaborators around the globe. As part of our ongoing strategic plan for the Department of International Health, we're committed to expanding the reach and impact of our work and continuing to foster true and meaningful interdisciplinary collaborations globally. As we heard this morning, the science and practice of international health is really more important than ever as we struggle as a global community to emerge from this pandemic. We've learned a great deal over the past year from our successes and find that we have miles to go as we recognize many failures to how governments and populations have responded around the globe. We should and can do better than we are doing now and in the future. The pandemic ongoing social justice movements around the world have really shed a glaring light, as Dr. Shumia shared from WHO this morning, on many persistent health system challenges, social and global inequities, and dysfunctions in how we operate at the local, national, regional, and global levels. And this is forcing us to confront the political and social status quo as we move forward. It's through this introspection and sometimes difficult yet honest conversations that we ultimately make progress. So today, in the spirit of this growth, we are privileged to bring you 3 sessions. The first is an amazing interactive panel hosted by our own Dr. Smisha Agarwal, featuring 3 colleagues who are thinking deeply about the decolonization of global health. As I'm Mkumba, the editor-in-chief of BMJ Global Health, together with other colleagues, including Madhu Karpai at McGill, wrote in a recent article on power asymmetries in global health last month in PLOS Medicine. This is a topic that we need to address at multiple levels, at the individual and at the organizational. So as myself, as a multiracial, multi-ethnic person, born and raised in Bangladesh to the Indian, Belgian parents, and now working in a leading Western institution in the US, collaborating with partners in Sub-Saharan Africa, in South America, and South Asia, I know that I'm eager to continue to grow in this area and to help promote organizational change wherever it's needed. Following that session, we have 2 lightning talks featuring colleagues from the school and country partners about their experiences in expanding inclusivity through advocacy and practice. Anita Shankar and Beth Frederick, who I'll introduce at that time. And then we will finish with another exciting keynote by none other than Dame Sally Davies, former Chief Medical Officer and Advisor for England, and the current Master of Trinity College at Cambridge University, the first woman to hold that post. We hope you enjoyed this afternoon's lineup and that it provokes new directions for your own work, your own thinking, and if you're a student with us, your studies. It's my pleasure now to hand the session over to my colleague, Dr. Agarwal, to introduce the panel topic and our esteemed guests.
Great, thank you, Alan. It is an absolute privilege to be able to host this session today. A very good afternoon, everyone. The term decolonization might be confusing to those of us who are from countries that were previously colonized. In the context of global health, it really refers to the asymmetries in power and decision-making that emerge from the colonial roots of global health. The global health ecosystem today continues to be largely centralized and homogeneous. And the recent challenges over the inequitable access to COVID-19 vaccine has been one critical manifestation of how these power asymmetries play out in a time of crisis. And it reveals with sobering clarity how power imbalances continue to disproportionately harm the most marginalized communities. So our conversation today is about how we as a community should be thinking about dismantling the colonial legacy that underpins our work. This figure here shows by Shea Abimbola and colleagues, shows how global health has many asymmetries in power and privilege, and every grouping has its own internal power hierarchies. Coloniality here to the right is just one of them. There are several other systemic disadvantages due to race, gender, caste, class, religion, etc. At Hopkins, we welcome students and colleagues from every continent, and each brings to bear their own unique experiences and perspective. So I hope that this panel will provide some thought and reflection and a safe space for discussion. Some of us may have borne the brunt of neocolonial practices in global health in our personal work, and others may have inadvertently become cogs in the wheel that actively or subtly perpetrates colonial malpractices. Next slide, Alan. We also hope that this is one of the many initiatives across the university that prompts us to re-examine how we must continue to grow and evolve this institution. And the very first step is having this somewhat uncomfortable conversation. In the words of Richard Hottenyer, any Western medical institution more than a century old and which claims to stand for peace and justice has to confront its painful truth, that its success was built on the savage legacy of colonialism. So with that, I will pass it on to our first speaker for the day, Laura Mukumba. We're absolute privileged to have her join us today. Laura is a native of Dar es Salaam, Tanzania, by way of Atlanta, Georgia. She received her Master of Science in Global Health from Duke University, where she, along with other colleagues, co-founded the Duke Decolonizing Global Health Working Group in 2018. And that was one of the primary drivers, I think, that really brought this issue to the forefront of many discussions. So absolute kudos to Laura. I hope she inspires many of our students to take similar actions during their time here. And so Laura has spent the last decade working in international and domestic HIV/AIDS research, as well as mental health, health equity, adolescent health, and sexual and reproductive health. With that, over to you, Laura.
Thank you so much for that warm welcome, Smisha. I am going to share my screen, and please let me know if you are able to see this. Take that as a yes. Okay. So for this, I just wanted to keep today's talk and kind of my portion really informal, and especially take time to reflect on what decolonizing global health means to me. And so like I like to begin with every talk that I give, I always like to give the positionality statement. And this is just a statement of me saying the social and political context with which I move through the world, but also recognizing that my positionality changes depending on the space that I'm in. So within this space, I am a Black African immigrant woman, and I am having this conversation in a predominantly white settler colonialist space. So I am currently living in Durham, North Carolina in the US, and this is a settler colonialist space. And I recognize that while I do have intersections of marginalization or marginalized identities, I do also have privilege through my cisgender identity and my level of education. And I also recognize that the work and the words that I speak today are definitely building off and are inspired by the work of queer, Black, Indigenous, and scholars of color who came before me. So first, I always like to start with key terms and definitions, and I just want to give a disclaimer that these terms and definitions were developed along with my colleagues from Duke, and that these are the definitions that I work with, and that these definitions are ever evolving. And so it is very possible that you might see me give a talk in a week and the definition might have changed, because as I learn more, I always also change the definition that I work with. So the first definition I want to highlight is imperialism, and I personally define it as the policy or practice of extending a country's power and influence through direct territorial control or military power. And then the next definition is colonialism, where it's the practice of domination and subjugation of one people to another through a transfer of a settler population to a new territory and the erasure of indigenous peoples' knowledge, culture, religion, and language. Now, people usually use these terms interchangeably, and honestly, there's still a lot of debate in, historians. Everyone has a debate on what each term means, but these are just how I define it. And the way I like to think of it is that imperialism is the thought behind the action, and colonialism is that action, and colonialism is also the structural power. And one thing I always like to highlight is that colonialism was and is a very violent practice and a very violent action, where it wasn't just about transferring the the settler population, but it was also very much intended to erase and subjugate the indigenous people's knowledge, or the indigenous people that were in that territory or space. So then when I move on to talk about decolonizing, I think of that as the process of dismantling these legacies of colonialism, and also specifically for that repatriation of indigenous land, that culture, that knowledge, and that language. Because colonialism seeks to erase that, decolonization should also seek for that repatriation and giving that back. So I am a very strong proponent of the land back movement. I am a very strong proponent of indigenous people getting claim and getting ownership back of their history, of their culture, of their language, and of their knowledge. And when I think of this in decolonizing global health, it's the same definition, but really especially in doing these systems of colonialism that govern the global public health agenda, and then also control these levers of power that lead to global health inequities. And actually, like I said, ever evolving definition, also really global health injustices, because recognizing that these injustices are also coming from structural systems of power that need to be uprooted and upended. So with this definition that I gave, one thing I wanted to focus on is talking about what decolonization is not a metaphor for. And I took this as obviously play from the paper by Tuck and Yang, where they talk about kind of some of the issues that they've seen with people using decolonization as a metaphor. And the first thing I want to talk about is that decolonizing is not a metaphor for reform. Now, just to give a disclaimer, everything that I'm going to list on this slide is not to say that it is a bad. Reform is not bad. It is not a bad concept. However, one thing I always urge anyone who's coming to listen to me talk or in any conversation is being very clear that when we call for decolonization, we're not calling necessarily strictly for reform, that it's going beyond reform, and also really recognizing that reform also sometimes means to just reform, meaning to just reconstruct it, and sometimes really not really addressing the structural, the foundation issues, but really just making cosmetic changes. And so I always like to be very clear, and I'm very specific, that when I talk about decolonizing, I'm not using it as a metaphor or a simile for reform, meaning that I'm going way beyond that, and sometimes reform is not enough and it's not what I'm calling for. It is also not a metaphor for diversity, equity, and inclusion. Again, diversity, equity, and inclusion are important. These are goals that we should strive for in every institution. We absolutely should have diversity in who is represented. We absolutely should have equitable representation, and we also should have inclusion. However, we have to be very careful to strictly end it at just diversity, equity, and inclusion, or DEI initiatives, because what that does is we can, again, going back to those cosmetic changes, looking at what the efforts that we've made, and then we sometimes will say, well, look, we have diversity, we're more inclusive, we might have a more inclusive culture, but have we really addressed the roots of the field that we're working in? And that's really, again, going to the crux of that decolonization. And again, along with that line, it's not a metaphor for necessarily just more representation. More representation is absolutely needed in our field. It is absolutely important, again, but let's be careful not to just stop at representation, and really to go beyond that and say we're going to call for representation, but we really also have to address that the field that we work with is rooted in some of these very structural oppressive systems, and that means that we have to dismantle those and destroy them in order to build a more equitable system. It is also not just fixing a broken system. And I have broken in quotations because I actually do not think that many of the systems we work with are broken. I think that they're actually functioning the way that they're meant to. And what do I mean by that? I recognize that if something is rooted in oppression, and people are being marginalized and oppressed as a result of it, that means it is functioning exactly the way it's meant to function. It is meant to function so that one group feels marginalized or subjugated, or one group is facing health inequities or health injustices. Now, I don't want to make this seem like it's a blanket statement to saying that all of us are we are promoting this broken system that is actually functioning the way it's meant to. But again, it's recognizing that if we really look back at the history of global health, we realize that it is just a newest iteration of what we once called colonial medicine, of what we once called international health. And when we look back to those previous systems, we see that really the primary goals of those were to protect the health of white people or the settlers that were going to these colonies that were usually on the African continent or in South Asia or South America. And also, they often were not always concerned with the health of the indigenous populations that were there. And global health has certainly evolved beyond that, and we have certainly are making an effort to be more equitable. However, when we, again, going back to that foundation, I always like to think of it, and, the metaphor I always like to use is that I think of it as, that there's sometimes where we're making cosmetic changes, but we really have to recognize that the house that we're making these renovations or cosmetic changes to is sitting on a broken foundation, or is sitting on a foundation that is rotten or that is sinking. And so no matter how much effort I'm going to make on renovating my house, if my foundation is rotten, if my house is still sinking, what good is that doing? And so again, recognizing that if the system that I'm working within is actually rooted in oppressive systems like white supremacy, like coloniality, like racism, like sexism, like white saviorism complex, that it's functioning the way it's meant to, and that we actually really have to dismantle that and not just fixing a broken system, but really dismantling this system that is very oppressive. And I think one thing to end off with this talk is that, as we mentioned at the beginning of this panel, is that these are very uncomfortable conversations to have, and it can be very uncomfortable to sit with the recognition that the world and the work that we do sometimes can be very harmful. And it's not to say that we ourselves are the perpetrators of harm, or that we ourselves are actively enacting harm, but sometimes we can be very complicit in the harm and the oppression that we might cause others. And so just being very mindful and being careful, but again, these are very uncomfortable conversations, and I always call for people to sit in that discomfort, acknowledge that, have that critical reflection, and really think of what are some ways that we move forward, and what are some ways that we truly decolonize, where we're going beyond just the cosmetic changes. Thank you.
Great, thank you so much, Laura. And I think that sets us up with a great introduction to the topic for our next speaker. We'll have a chance to have more for discussion at the end of this panel. But if you have any questions in the meantime, please enter them in the Q&A box. Next, we have Dr. Tammam Aloudat, who's the Deputy Medical Director of MSF Switzerland. He's a Syrian medical doctor and a public health expert who has worked for the International Red Cross and Red Crescent Movement and for the MSF in the field and headquarters to support emergency medical assistance in multiple contexts. Tammam has a medical degree from the University of Damascus and a master's degree in public health from the London School of Hygiene and Tropical Medicine. He is also one of the speakers that I had a chance to interact with in a bit more depth before this panel. And I am very excited, Tammam, to have you here today and talk to us and your great insights. Thank you.
Thank you. Thank you very much for having me. I really appreciate the opportunity and the challenge of speaking after Laura as well. There is plenty that is being said about coloniality and decolonizing, and part of it, as Laura said, the paper of 2012 by Nanyani is one that raises an alarm, and it tells us that decolonizing isn't a metaphor that should be used lightly. Actually, they sound in their paper to be saying that we shouldn't use decolonizing that isn't expressly about the repatriation of land and culture and reparations as a metaphor for anything, no matter how just and right it is. And I will build on Laura's argument a little bit. And make an exception, because I disagree with Nanyani on one thing. They talk from a very clear position of settler colonialism. And mind you, as we stand today, there are 5 or 6 countries that are still settler colonialist countries. And those are the United States, Canada, Australia, New Zealand, and Israel, Palestine. And in that sense, this is one section, and I fully agree with them on the risks of addressing decolonizing fairly lightly in a settler colonialist context. However, most of the previously plundered countries, I don't know what to call them anymore, because I keep finding problems with the global south, middle income, low middle income countries. And so let's say the previously plundered countries, many of whom are still plundered today. The problem is that we have had a very different context, is what Laura called imperialism, which isn't about settling people as much as it is about extracting resources and exploiting. And those resources ranged from metals and natural resources to people in the form of the European slave trade. The point I'm going to make is, rather than talk about colonialism or decolonizing as an absolute metaphor, I will mention a couple of things that I think fall into that vague space whereby we can actually use the metaphor for good. And the first, a few weeks ago, I was asked to do a psychological test for my evaluation. That's one of those you fill questionnaires online. And I was told afterwards that I'm way too abstract and theoretical, which is, for some reason in the humanitarian field, that when people tell you that, it sounds like a criticism. I was very happy about it. So I'll start with an abstract bit. The abstract bit is about knowledge, is about what is knowledge. And in our current discourse, there is plenty that is being talked about, knowledge related to global health. And I will start by a tongue-in-cheek example, which is this one. When I say medicine, most of you will think of this. And I could have had any number of pictures, but Grey's Anatomy is as good as any. This is a hospital, absolutely generic, could be done in any Western country. Crew that is calculated better than usual to reflect all the ethnic and gender, sensibilities of society, and is completely apersonal, the images about the doctors rather than about the patients. And this is a very accurate depiction of global health today. However, if we were to dig a little...
Ma'am, sorry, if I could interrupt you. You see your screen is not fully shared and we see a number of
oh, sorry.
windows up.
Let me, is that better?
Yeah, that's better.
Okay, perfect. Let me give you another image. And that image is this one. This is an image that sits in place of a photo of my own grandmother in a small village in southern Syria. The reason I don't have her image is because she was never photographed. She died in the late 60s, and I don't know of a photograph of her. But she was the healer of the village in a time where going to a Western-style hospital was inaccessible to almost anybody. She was also she was the one who set bones, who treated people with herbs, who cared for children, and who actually also arbitrated land disputes and knew the history of the village and the families and the genealogies. This is how medicine looks to millions of people until recently, and in many cases until now. In my country, in Syria, until recently, until we have decided that unless we entirely Westernize, we're not good enough. A doctor was called Hakim, and Hakim in Arabic means a wise man, because doctors were expected to be a social force, not only a biomedical diagnosis machine. And that isn't the case now, unfortunately. The reason of that is that we have been made, and I am telling you this not as an evangelist in any sense. Until very recently, I have been a fully indoctrinated biomedical Western style physician, and have, I could go to AA meetings if they existed for this kind of stuff. We have knowledge expressed in ways that only reflect a very small slice of humanity. This is expressed clearly in the sense of that was mentioned by Shaya Bimbola actually a couple of times. The Western gaze, the how do we do research? The journals that count as journals of repute that are invariably sitting in the West, with Western editors. The fact that there is an explicit bias against publishing by people from the global South, that we have new evidence of much publications that come in the name of people, researchers who get the funding rather than who do the work on the ground, and so on and so on. This is one side. Another side is one of consuming knowledge. You guys have the absolute privilege of having Johns Hopkins resources that any article in the world, I assume, is a couple of clicks away. That isn't a privilege afforded to almost anyone else in the world, let alone universities. I have worked for MSF, and we tried to engineer access to pay just like a university does. So we in the headquarters, but also our physicians, colleagues, nurses, and so on, have access to medical literature in project countries. And that would have cost us $1 million a year. I don't know how universities do it. I've negotiated myself for a couple of years with multiple middlemen and publishers and so on. And in the end of the day, it's $1 million a year is the cost of a hospital, a middle, small size hospital. And that was a sacrifice, a replacement we couldn't do. But it's not only the expense, but it's the mythology created again, around it. So what I can show you now is also another example. A few days ago, there was this on BBC, which is that the chief of police of the city of London warning students that using Sci-Hub, I don't know if you ever needed Sci-Hub as students of Johns Hopkins, or if it's legal or illegal to use it in the US, but it is a website that gives you free access to all journals. Warning them that this might put them at risk. You dig into the article and it's talking about how illegal and immoral it is. So we are in a time and place whereby the chief of police of the city of London, and if you don't know London enough, London police is called the Metropolitan police. The City of London is that square mile where all the banks and investors sit. Those are the guys who lost the billions of the collapse of 2008 and never got accountable. And that chief of police who'd never arrested a banker is threatening students who want access to journal articles. So the consumption of knowledge is neither democratic nor available to people who do not come from privilege. But all that I'm arguing is on the surface only. And knowledge is deeper than that. Knowledge is what qualifies as legitimate knowledge and what we accept the world to be in its perfect shape. And my argument is that this knowledge is entirely biased towards a certain set of facts and assumptions that are based on Euro-American, Western European mostly culture. This is partially how we understand and apply medicine. When I studied, I don't know about you, but when I studied medicine, we studied every possible disease, even the ones that we wouldn't have seen in a million years, including tropical diseases that none of my colleagues in Syria would have seen until now. But we never studied medical ethics. Was an elective, and social medicine didn't exist, and social determinants of health didn't exist, and so on and so on. The boiling down of knowledge into a biomedical knowledge, it almost plays a trick on your mind that, we're all the same under our skin, which is a good saying when you're talking about, people are equal. But it's not good when you're talking about health, because yes, under our skin, we're always the same. But beyond our skin, we live in conditions that are entirely different. And we live under determinants that tells us whether we will die when we are 50 or we will live to be 85. And this is where the map plays aside. So colonialism, the view of the world that designs projects, that assigns resources, that governs it, that decides who qualifies as a health worker and who doesn't, what are the minimum standards, and who deserves health and who doesn't, is one that is almost directly inherited from a history of colonialism. And don't believe me, I will give you a couple of examples, because my advocacy is not to decolonize, as was advocated by the militant anti-colonialism of the 60s and 70s. I'm not asking anyone to carry a weapon and go decolonize global health. My argument is that we have 100 years of literature and understanding that we need to use to be able to dismantle the power asymmetry, accepting that this power asymmetry is inherited from a colonialist past, and understanding that this overlaps with gender inequality. It overlaps with homophobia, it overlaps with Eurocentrism and ethnocentrism, Islamophobia, anti-Semitism, and all the diseases. And to add to it, with hyper-nationalism, and with all the issues that make people apart. And we see it now, but others saw it before. So one of my favorite authors is Bell Hooks, who's a feminist, militant feminist. And she calls what I am trying to describe the imperialist, white supremacist, capitalist patriarchy. And it is, there's very few names that describe it that well. And here I will stop for a second. I have a couple of minutes left. I will say that my point isn't that we all need to become militant decolonizers of global health, but we cannot go on practicing it with our privilege without examining our position. What is it that we are doing, and how are we affecting it? So, and to be very clear, I'm not talking about white people. This fails if it becomes about people of color against white people, or people from the South against people from Europe and North America. I'm talking about a continuum of privilege where each of us is put in a position where we are victims of the system, not only the racist imperialist system, but also the patriarchal, the hyper-capitalist system. And all of us, by being positioned in global health, are also perpetrators of that system. I'm not asking for all of us to leave our jobs. I'm asking for us to think about where we are. So let me give you a couple of examples. From that literature that we're talking about, before my time goes up, I think I have a couple of minutes. One of them is Fanon. Franz Fanon was a Martinican anti-imperialist, anti-colonialist thinker. And his last book was completely disillusioned, The Wretched of the Earth. He was saying, carry guns and shoot colonizers. But before that, he wrote Black Skin, White Masks. And what he says is fascinating. As the colonized, as the oppressed, it's not only that we submit by force, we internalize our assumed inferiority and accept it and practice it and sacralize the colonizer and the oppressor and try all we can to be like them. And that's the first failure. And this is where, Laura, you were talking about diversity and inclusion. Those of us who have spent our lives, me included, trying to assimilate and think and behave and talk like the perfect image, we're wrong. And we need to re-embrace where we are and what makes us different. The second one is Edward Said. And Edward Said is a Palestinian-American philosopher who wrote Orientalism. And it's fascinating because in his argument, a long book that can be summarized, in my opinion, into the Oriental doesn't exist. We invent them from the imaginary. We invent, the Orientals from the accounts of uninformed travelers of the past, from art, from literature, from so on. And then we behave as if they are real. And here in global health, we invent our patients and the community. We invent their inferiority. We invent their ignorance. And I'll give you an example. In the West Africa Ebola, people who washed their dead as a tradition were called super spreaders because they were supposedly increasing the R0 number, the infectivity of the disease. They were infecting more people. People who didn't respect they were called themselves super spreaders. In the US, even when people intentionally go and sit in the White House lawn a few months ago in an event without masks, none of them was called super spreader. Go to the news and dig it out. The event was called a super spreader, but the people weren't. People who practice traditional behavior in sub-Saharan Africa are called ignorant. People who go to the church in Europe aren't. And if you look at the images, and I'll show you a couple of them just for the heck of it. This is my last one about knowledge, is we look at things like that as a norm. So this is a patient from West African Ebola. This is a woman who's unconscious, might be dead or dying, and being examined, exposed, and probably without any meaningful consent. This is how we display a person that we don't believe in the full humanity of. You look at the images of COVID-19, and this is an image from the exact same website, our own MSF website. And this is a woman in Europe who is dignified, looks like she's being helped kindly, she's conscious, and you could even interpret a half a smile on her face. She is in a dignified position, and that's the difference. You could Google hundreds of images of dead or starving children in the global south. You could never find any of those at least after the Second World War in Europe, almost at all. So how do we perceive people? And what makes us do that is important. And my argument is that is where we need to work as practitioners of global health. So instead of submitting to what we are told is good, we need to think differently. Yesterday, the US administration agreed to a waiver on the patents on vaccines. And that's a good thing. I still reserve judgment because I don't trust governments generally. But this opposes a rhetoric by someone like Bill Gates. And if any of you hasn't read it, go to the New Republic and read the argument in an article that is called Bill Gates, the Vaccine Monster. And this image is from the New Republic. The guy who governs global health with nothing except his money still stands against sharing the patents of vaccines, because he built that fortune on monopolies of information and on patents. And this is where each of us needs to think about, how do we perceive the world? How do we see others? Where do we stand in that continuum of oppressed and oppressor? And how can we oppose it from our position without even going out of our way and, you know, waving flags and going into protests? Thank you very much.
Thank you, Dr. Aloudat. That was incredibly enlightening, and look forward to more discussion on that. So finally, we have our last panelist for today, Dr. Aletta Nonyane, who's a faculty in at our school in the Department of International Health with expertise in statistics. So I will hand over to you, Aletta, to take it on from here. Thank you.
Thank you very much, Smisha. Thank you very much, everyone, for having me. And I'm glad that you asked me to go after two great speakers, because I can just repeat what they've said. So when I was invited to talk about it, to be honest, I knew that these are the things that I think about actually on a daily basis, but I hadn't really thought about putting it all together for a discussion like this. And I thought the approach that I would take is to talk about what I understand, what, you know, decolonizing global health sort of means, at least to me. And so the title of my talk is how do we renew our approach to conducting global health? So I want to start off by just saying that you know, we need to acknowledge, and obviously we all have evidence in front of us that a lot of public health gains have been made over the decades in global health, including examples such as reduction in child deaths, improved access to healthcare services, and all that. And that progress has been achieved through collaborative efforts between low middle income nations and high income nations. And just like you, Dr. Aloudat, I also struggle with terms as to how to refer to these countries. So these achievements have been attained through a funding structure where the majority of the funding for, say, research projects and interventions comes from higher income countries. And as a result, we are faced with challenging power dynamics, some of which have been alluded to by the previous speakers, and some political forces and influences that are transferred to the practice of global health that lead to a perpetuation of inequities that we see in front of us today. Now, what do we mean by decolonization of global health? At least to me, what does that mean? I'm citing here a phrase that was used by Professor Mamokgethi Phakeng, who's the Chancellor of the University of Cape Town. She was talking about decolonizing academia. Actually, she was being interviewed. And so the way she described it is, you know, what I believe, it's not about dismantling what we already have and starting afresh, but rather it's like renewing the approach to how we do things. And so in our context, it would be, how do we revise the approach to global health practice? And so how do we do that? There are a lot of things that I could go on a whole day about, but I just thought I'd speak about a few. The first one is understanding our history, which, you know, Dr. Aloudat has mentioned, and also Ms. Mkumba has mentioned. Understanding our history, by recognizing those who make significant contributions, irrespective of who they are and where they come from. And also, how do we talk and write about global health? And then many others, but I have limited time. So when it comes to understanding our history, how do we renew our practice, how do we do that? And as a step towards renewing the way we do things is understanding the history. I was listening to a talk by Dr. Anusha Bhattacharya. I can't say her name very well, I apologize. But basically what she was talking about is like, we need to recognize the history that we've inherited, understand where some of the policies and the structures that we're operating under come from. And in my mind, when I was thinking about that, I thought about specific examples, such as who sets priorities for funding and why. An example being, would a landscape analysis of say, a country's disease burden needs reveal that non-communicable diseases maybe should be given higher priority than what we're currently seeing, So there needs to be discussions around issues such as that. And this is, as I said, is just one specific example of who sets priorities for funding. Another example related to that is the recent discussion that's been held by the NIH around the review process and broadening the reviewer pool. Now, once again, on the issue of renewing our practice, I mentioned that one of the biggest issues is recognition for those who make contributions to global health, and advocacy and addressing biases in media reporting of global health. I think we have a responsibility for doing that. And I just have here an example of the Congolese doctor who actually is the one who alerted the world about the Ebola. And for a long time, he did not get this recognition as the person who actually made the world aware of this disease. Another one is the skills transfer for communicating research findings. I think Dr. Aloudat mentioned something related to that in terms of academic publications. Oftentimes when researchers who are based in high-income countries or Western countries, those that they work with in low middle income countries usually don't have supported time in order, even if they were interested, or even if it would help contribute towards their career progression, they don't often have the time, the support to be involved in communicating research findings. So in the end, we end up having people from the Western institutions being recognized for the work that they do. While that is true that we need that type of support, it is also important to watch out for tokenism, where we just make symbolic gesture and put people's names on publications just for the sake of, of showing that, they are recognized. But what is important is for them they need to be supported so that they could actually do and lead their authorship. And the third point I wanted to talk about, of many that I have thought of, is how we read and we talk and write about global health. And Prof. Aloudat mentioned some of this is the avoiding stigmatizing language and visuals. This is something that I feel that needs to be addressed. And right in our school, for example, sometimes when I walk through the corridors of the School of Public Health and I look at some of the pictures that we see there, I have questions. Now, one thing I want to make clear is that I understand that having pictures like this helps sort of describe the context of our work and why our work is needed. But then how do we do that in a way that is not stigmatizing? So I think we need to have conversations around that, and not just conversations, but some actions around that. And then continuing on the issue of visuals, the people who appear in pictures, Dr. Aloudat showed the picture, the two contrasting pictures of women who were both needed healthcare, but the way they were depicted in those pictures was very, very different. And in some instances, I ask myself, did people actually consent to appearing in these pictures? And if we say they did consent, did they really understand what it meant? You know, to consent to having their pictures sit on our walls for many years, and what those pictures depict. So, and related to that is the enforcing of ethical standards. I think some of the collaborating countries may not have the resources to strictly enforce the ethical standards. And also another thing about how we related to how we talk and write about global health is the language that we use, the assumptions that we make that may ignore or undermine the culture of the country that we're working in, and not respecting the cultural influence on health behavior. And I think Dr. Aloudat mentioned that in the context of Ebola as well. So in summary, I just want to say that we do need to make space for diverse perspectives, and I agree with Ms. Mukumba that, you know, diversifying colonialism is not like a metaphor for diversifying, but I think making space for diverse perspectives is important in our quest to renew or decolonize the way we practice global health. We need to recognize and leverage the power and privilege that we have. This is actually something that Dr. Aloudat mentioned, which is that we are here in this space. What is it that we're doing with the power and the privilege that we have? Because it takes individuals in order for institutions to change. So, in summary, we need to review and look at our existing policies, the history, and if available, oftentimes we do have a challenge that we don't have data that are available to help us in order to generate recommendations to change the way we do things. And finally, I just want to say that this is all recognizing the fact that a lot of progress has been made, it continues to be made. And so we do need to keep marching on, but it is important for us to sort of stop at some point and sometimes stop and think about the impact that the way we practice global health has. Thank you.
Great, thank you, Dr. Nanyani. I'm also thank you to all the panelists for really staying on time, and I see a lot of great questions in the chat box. So, looking forward to have that discussion. Aletta, as you started, you said that you've thought about things and never quite articulated it. And I think if I might summarize some of the comments from the panelists today, there is a process of learning how to work with the system and simultaneously unlearning as we go back to our roots of what drove us to work in this area. And I think that really for our students, as they embark on their careers in global health, must continue to reflect on the very foundations that drive our work, and at each step, realign ourselves to the intent that drove us to the work, rather than what we've come to learn in the system that is fundamentally tainted by its colonial roots. And so, in practice, this means that as you go through your education and careers, you question the nature of our partnerships with collaborators. You question who holds the purse strings, you question who gets a seat at the table and why, and you question who is funded in global health, what is funded and why, and you question why you are where you are in your careers. And sometimes you pull yourself up to the challenge because you don't have any role models. And at other times you step aside and let a colleague who doesn't have your privileges shine, right? So it is really recognizing when you need to step up because, you know, to Dr. Aloudat's last point, where we don't really see, or we feel the need to align with the system we're enter into, but at other times really be an ally to those around us. So with that, I will pass on to Alain Labrique to take us into the Q&A, and I see a lot of great questions, so let's dive in.
Fantastic, and you know, as all of you have said, these are not easy conversations. These are not simple conversations to have. the last thing we want to do is be, you know, reductionist or to not give due shrift to the depth and profoundness of the questions that we're asking. So I wish we had 3 hours to explore this, and you know, I think where we are in the juncture of the trajectory of global health is that we are having these conversations, and we are putting words, as Aletta said, to these feelings that many of us have struggled with and continue to struggle with. So I think this is an opportunity for us as faculty, as global health leaders, as students, to shape what global health looks like in the future. And let me ask, I'm going by the number of votes, and so I'm going to actually ask people to unmute and speak, because I think that's rather than have me your voice, let you be your voice. And Alex Kaysen, you want to ask your question about funding, and let's have folks weigh in on that.
Hi, can you hear me?
Yeah, perfect.
Yeah, great. Yeah, so my question really has to do with the structure in which global health operates. You know, you have so many large foundations and government agencies which really control what projects are operationalized and who gets funded and the timelines. And given that structure, if it remains in place, can you really hope to achieve some gains towards a more equitable relationship and just more aligned power dynamics between the Western governments and universities and those in low and middle income countries?
So any of the panelists who would like to unmute and maybe take a stab at that? And I think there's several other people who have asked similar questions, Stephanie as well.
If I may, I will say, no, of course not. It cannot, you know, looking at COVID is enlightening, because COVID exposes all the diseases of global health very acutely and severely. So the fact that now the US is looking at certifying the vaccine for 12 to 15s who are at very low risk, while we still have half the world without even frontline health workers being vaccinated, is one example. And that's why I tell you, I keep caution, even with the Biden-Harris administration agreeing to the waiving the intellectual property. The fact that Canada, you know, those are the nice guys, ordered 5 times the amount of vaccines they needed when they knew there's no one else going to be able to afford it. The US ordered twice, UK twice, Germany, France, and so on. The fact that they've started, you know, we've been pushed towards a neoliberal, hyper-capitalist life for 40 years now. And suddenly when hits the fan, suddenly they stop, they put restrictions on exporting. Their structural adjustment, which was forced on poor countries, forced them to liberalize their policies at the expense of health of their people. So it's not only that nationalism and hyper-nationalism is bad, it's even applied variably. So to say, you know, I could talk about the actors in global health and who has the influence and who has the money and so on. Of course not. But then we are faced with a problem. In my opinion, if I was an Algerian in the 50s, or a Congolese under, you know, Belgium, or you have no solution except driving the colonizer out, because they're all bad. Here, we have a system that is actually providing care to people. It is fundamentally flawed, but none of us is in a position to say, you know, go off, take your money and your health and your hospitals and whoever dies, dies, as long as I decolonize. That's not a moral position. So we have to find the balance whereby we move the system without harming people. And I say that not jokingly, because I saw a video on YouTube once from a university in the US where someone was saying, a student meeting was saying, biomedicine is a Western colonialist invention and should be abolished. And those guys are called the fallists, the fallism movement. And, you know, yeah, you're sitting in the US and aren't exposed to measles without vaccine. You know, you're not in a position to ask children in another continent to be exposed to vaccines, so you make a point. So this is the careful navigation we have to do between understanding what's bad and not harming the people we're trying to serve in the process.
Aletta or Laura, do you want to weigh in on this?
Yes, I would echo those words. That I think in my last slide I talked about we do I said we should leverage some of the power and privilege that we have, but I also am cautious because you know that is also limited, right? Just because we're here in this space and we're able to speak up, but I think it is worth taking small steps. Small steps, but bold steps towards changing the way we do things. I do understand that money is a big motivator for a lot of the things that we're talking about right now. For example, when we were talking about the waiving of patents for patent restrictions for vaccine, like this morning on the news, I didn't pay a lot of attention, but I think I caught wind of the fact that the pharmaceutical stocks sort of plummeted. I don't know if that's the word they use, but they went down at the news that the US government was considering this waiver. So there are always going to be forces that make it difficult, and they're usually related to finances. They're going to make it difficult for us to make progress towards removing these structures that, you know, the legacy of colonialism. But I don't think that not doing anything is an option.
So, Laura?
Oh, I was just going to quickly say, I absolutely just agree with what Tammam and Aletta both said. With definitely, it is this delicate balance. And, you know, I know even in my presentation, I talked about dismantling and, you know, this destruction of these structural powers and oppression, but also recognizing that they're so embedded in everything that we do. And even in, you know, we have, I think in the global health field, many of us have been able, not have been able, we are, a lot of us, most of us, I would even say, are doing good work and are working towards addressing these health inequities globally. But I also, you know, echoing with what Aletta said, with small, bold actions, and especially anti-colonial actions, and really pushing to change some of these structures, especially funding structures, and really, you know, going back and pushing back and saying, we need to talk about how we are funding interventions in, and I'm going to use the problematic term, global south. We need to talk about the distribution of knowledge from these interventions. How does that knowledge go back to those settings? I think there's small steps that can be made. In an idealistic world, yes, we would absolutely, everything would be just and equitable, and we wouldn't have have this fight. But realistically, capitalism is at the root of a lot of what we do in this world, and so that is a big structure and a big power to fight against. And there are things that we can do, like I said, those small anti-capitalist steps that we can take. Absolutely.
I mean, certainly we've seen this issue play out in the funding of global health research. But I wonder, thinking back to the 2005 Paris Declaration on Aid Effectiveness, underlining the principles of country ownership and alignment with country priorities, harmonization across funding partners or donor countries, as they like to be called, and you know, trying to stress the importance of accountability with this concern about corruption and graft towards funding. I mean, the Accra Agenda for Action, you know, that was put into place in 2008. I mean, were these incremental steps towards greater country leadership, or countries being in the driver's seat when it comes to determining their own health trajectories?
This is so fun. We don't get to speak about that in panels before. So I'll say something. You know, there was a question as well that alluded to something like this. First, you know, this whole discourse about corruption is funny, because there's an assumption of corruption if you localize or give countries or communities. You know, we're afraid of corruption. No one is afraid of corruption when you give an international organization money, but everybody suddenly freaks out about corruption, whether you know them or not, because the underlying assumption is whoever comes from that part of the world is corrupt until proven otherwise, and vice versa. So that aside, yes, if we're learning from history, let's learn from history. Many of the countries that decolonized ended up in dictatorships, and ended up in corrupt and brutal dictatorships. And people who will argue against the decolonizing argument will say, you know what, do you really want that to repeat? And of course not. Eliminating one evil doesn't guarantee that the next one wouldn't happen, but at least we have a way of anticipating it and working against it. The second is, you know, part of why I struggle with Alain in the discourse is the argument on aid, on aid effectiveness assumes still full sovereignty of states over their people. And that's a big assumption. There are many states that aren't really that concerned with the health of, with the equal health, at least, of all their people. So that pains me a little bit. This is not the solution. And this goes to the reform. So, you know, reform, you'll have people who are allergic to reform as an expression, and others that are not, but we don't define it. Reform is seen as keeping the structure and changing stuff within it. But then there was a guy, a French philosopher in the 60s, I think, Alain Geertz, André Geertz, sorry, who wrote about non-reformist reform. I say, reform, don't burn the house. And he was talking about labor movements at the time, not about health, obviously. But don't burn the house necessarily. You don't always need a revolution, to solve issues. But don't keep the house. Don't do everything with the aim of keeping the structure going. So when we talk about reform, of course, we're not burning global health. That's not the point, as I mentioned. But we're not going to do it with the aim of keeping capitalism and nationalism and social, and national structures and authorities and all other diseases, going on. So this is the difference, because it might not change what I do every day, but knowing what the goal is, and this is a huge definition for everybody individually. When we talk, all of us talked about capitalism, and I always, wish I could see the faces of people, because, in Europe, this is not a scary thing to criticize capitalism, but if one watches, the US media, I'm happy I'm not there, because people might have pitchforks if you talk badly about capitalism. Nancy Pelosi answered the question recently when she was asked about, we're capitalists and that's it. And she's accused of being a radical leftist. So that aside, we need to understand what are the root causes, even if we don't go, and fight them every day, but we need to understand them. And in my personal, completely biased opinion, those are national populism, capitalism, and the legacy of power differences that come from colonialism. And every time I'm doing something, whenever I have a leverage to think or do something, I think, am I enforcing them, or am I, chipping at their bases? And that's the difference. Those two are reforms, but are very different reforms as well. So yes, it's a good thing that we have the effectiveness of aid declaration from 2005, but it aims to enforce national authority and the authority of governments unconditionally over their people as well, which is not necessarily a great thing.
I have a number of questions here which really get to a point that that has been in the debate, academic discourse for some time, and that's the role of the Western institution. Jonta, with apologies, I'm just going to paraphrase your question to Laura, which is, you know, how do we decolonize global health in our work, especially as we study and collaborate with LMICs coming from Western institutions? So wherein lies the role of the Western institution going forward? How do we redefine and support countries that we have worked with, collaborated with institutions in formerly plundered nations, and you know, what do you see as a concrete set of actions that you know, we as researchers in a Western institution should be examining and taking?
No, that's a really, really good question. It's actually a question I get a lot. When people always ask for, okay, well, what are some actual steps that we can take towards decolonization? And I think Tammam and Aletta both mentioned this in their talks of recognizing the privilege that we have when we're sitting within Western institutions and the power that we have and the power that we can wield, you know, towards working or acting towards change. And then also recognizing and having that moment of critical reflection, recognizing when you need to sit down and let somebody else speak and do the work. I think there's that balance of recognizing when you're the one who needs to act, and there's recognizing when you're the one who needs to sit down and listen or let somebody else do, do that work. When I think of concrete actions, it actually also, going back to Aletta's presentation, talking about pictures on the walls and talking about you know, when we're examining why do we have these pictures on the walls, that's actually what inspired my colleagues and I to start the Decolonizing Global Health Working Group, because we were asking those questions for our administrators. We were saying, and I had been at Duke for undergrad, and this is in grad school, and I was like, I've seen these pictures for almost a decade, and I'm really curious if the people who are photographed knew that they would be on the walls for this long, if they knew who was going to see them, and if they knew that they were going to be depicted this way. And one of the concrete actions that we gave them when we gave the recommendations was, well, let's start with thinking of, you know, the ethical practice of when we're sending, this is speaking from a trainee perspective, when we're sending trainees to these communities, let's talk about how we're interacting with members of those communities. Let's talk about how we portray them. And one action that we said was take those pictures down. You know, we're like, these pictures are not, this is not portraying a relationship that is respecting, where I was like, if I'm looking at that, and again, I'm speaking as someone from Tanzania, I'm looking at a picture that has the caption of taken in Dar es Salaam or Moshi. And I was like, if I was in that place, if I was seeing that, I would not think that this is depicting me in a respectful way. Granted, I recognize that I'm coming from a very Western view of what I consider respect, so there's that nuance. But I still think of, you know, when I say talking about what are some ways that we build ethical partnerships or, you know, equitable collaborations, let's, as Aletta mentioned, let's talk about, and Tammam mentioned, let's talk about how we talk about our partners, how we're depicting them in our work. So that was one thing, you know, that I've given in the past. And the other thing that has come up is, you know, this idea of authorship. And there's always this, and there's been discussion on how a lot of times when we're having these collaborations, the partners are from the LMICs or the Global South are usually stuck in the middle. And oftentimes what happens is we'll have us in the Western institutions where we write the paper and we just, you know, put the author list there to say, oh, look, we included our partners in the paper. And actually just this morning, I went to another talk about decolonizing global health in Africa, where there was an African scientist who said, I once got a paper that was already written and my name was on it. And I was just asked to say that it was good to submit for publication. And he was like, no, I want to participate in the writing of this paper. If I participated in the data collection and the design of the study, I also want to participate in the writing of that. So that is another action that we can take. And, you know, when we are designing, I think of, even for myself, again, I am just a young professional, but I think of when I am writing about the work that I've done in Tanzania, which is where most of my research has been based on, I am intentional about saying, I'm not going to just write the whole paper and then say, I'm going to stick your name in the middle and here sending it to you for your approval. I'm having that collaborative effort and recognizing that they also have very valid contributions to make. So those are just, without going into, me talking for so long, but those are just two things I always think of very concrete steps that we can take when we're sitting in this Western institution, and the privilege that we have and how we can leverage our privilege to make actual change.
Thank you, Laura. Aletta?
Yeah, just to follow up on that, I totally agree with what Laura was just saying. And when the question is asked, what can we in Western institutions do to ensure that the concrete steps that are taken? I have actually come to realize, and I think institutions have also come to realize that just as we need, as I suggested, that there should be more support for collaborators in low-income countries to basically financial effort, like protected effort, time to sit and contribute towards writing, communicating the research findings. I think the steps towards decolonizing or renewing the way we do also, just as institutions have been investing money in efforts for diversity and inclusive stuff, I think, we've seen how institutions have paid positions for these kinds of work. And I think it does place a lot of, I don't want to say burden, but extra work for us. We recognize that we need to be active in this and work with our colleagues who are of European descent, or in ensuring that we dismantle this legacy of colonialism. But at the same time, when you are already overcommitted in your research work, it becomes sort of just a very difficult thing and to engage in, or like put more time into. But I think we need to extend it for, just like we've done for diversity and inclusive efforts, we need to extend it for those of us who want to do the work, sort of like what Laura did, although I think it was an effort by the students to start this it took, I don't know whether it has become sort of a paid position of some sort, but we do need to advocate for that as well, to have people who want to be involved in the decolonizing global health efforts to have some of their time protected in order to engage in that work. So I think that's the way in which we could see concrete steps.
Yeah, that's a phenomenal suggestion, actually. The word intentionality is just rattling around my head here, because it really speaks to the necessity for us to be deliberate and thoughtful and intentional in how we think about our daily actions as global health practitioners, and in interacting with donors, and interacting with funding agencies, with partners on the ground. So building on that topic, as an institution where our core task is in training and forming future practitioners of global health and future researchers, we often send students to countries to gain experience, to work in the field, to appreciate the challenges of conducting research on the ground. And we have with us today, two of our leadership from the Center for Global Health that sponsors a lot of this work. So and student opportunities. And so I'd love to maybe have Anna Kalbarczyk or Tom Quinn weigh in and maybe join the conversation around those activities. Anna?
Yeah, thanks, Alain. I mean, this is something that I've been thinking a lot about, and I'd love to hear, because Laura, you talked about Western institutions, right? And we're talking about training as well. And this afternoon at the noontime session, we had a bunch of poster presenters, which historically would be all from students who had traveled all over the world. So I'd love to hear your perspectives on training models, right? What we do, how we can be thinking about how we train the next generations in global health, and do it thoughtfully, right? So not, I mean, and I'm thinking like, how do we create meaningful experiences for everyone, for our partners, for our students at institutions, but still kind of creating some of the benefits that come from traveling internationally or working internationally or embedding in a different institution. So I'd love to hear your thoughts.
Oh, I can go quickly as somebody who recently completed her graduate fieldwork just 2 years ago. One thing that stuck out for me, and I think that in terms of training models, is really thinking of how your trainees are prepared before going into the field, and what that preparation looks like. I won't go into details about what my preparation looks like, but I will just say that there were times where it felt inadequate, and there were times where it felt that it wouldn't actually prepare me. And even though I was going back to Tanzania, my home country, I can even say, as someone who had the privilege of being able to leave after 10 weeks, that it wasn't preparing me to recognize the position that I would occupy in the space that I was going to occupy going into that community. And one thing that I even suggested again to my institution was saying, this is difficult, and it might be difficult to implement, but you need to create space where students are reflecting, truly reflecting on the space they're going to occupy when they're going into these communities. Whether it's going in their backyard and just going to another state in the US, or whether it's traveling across the world, but recognizing, what positionality are you going to take in that space? How are you going to move through that space? And I think that sometimes, we focus so much on how to design surveys and how to, consenting and, IRB submissions, and that's very important aspects of training future researchers, but also and not to just, reduce it down to cultural humility, but also again, cultural humility, and really recognizing that competency of what space, where are you going to, and how will you move through that space, and how will people be affected by your presence in that space. And the other thing is also just that I thought could have been done differently is, and this is difficult when you have a very large program and you have a large cohort of students going on the ground, right? But also encouraging students to really recognize the history of where they're going. It's like, do you know the history of where you're going into? Do you know the reason why, if I am going to, and my work is HIV, research, I was like, I would have loved to know that the reason that we're still combating HIV, incidence and prevalence in Tanzania. So I'm like, we should have talked about structural adjustment programs and how they contributed to why we're still tackling these issues almost 40 years, almost 50 years now later, why we're not seeing the same level of response as we've seen in Western countries. And that is something that is, it was something that I did for myself, yes, but I think as administrators or as professors, also making sure that that space is cultivated for students to really have that reflection and doing that work, because that goes a long way in even informing how you're designing your project and what questions you're asking and how you ask those questions and how you disseminate that data. And something I mentioned just quickly is also, removing the emphasis from training being that the field is only international, and recognizing that there are health inequities within the country itself. And that is something that, again, I've also emphasized to my previous institution, is saying, there are health inequities right here in Durham, North Carolina, that we could do a fieldwork project on, and you can learn from, that you're addressing, that there's, marginalization and oppression happening within the country that we're in the US, and encouraging students to also explore, looking at opportunities that are here within their backyard or within their own country, versus just always promoting international. Not that there's anything wrong with that, but also just encouraging that it's not just always you traveling from the US or from, any Western institution and going to, and I'm going to use this, to Africa, which is what I have heard, right? And so really encouraging where it's encouraging students to say, is there a problem, unless you're talking about a tropical disease that is endemic and only, in one country, of course, I get it. You're gonna have to travel there. But if there's something that you can address where you are at, encouraging and also providing space and opportunities for students to also do that as well.
Laura, can I reflect really briefly on that last point? I mean, I think this is something where students have felt pressure, right, to do these experiences because they think it's what's going to get them hired, right? If you don't have global health experience, you can't get global health experience. So I think this is a wider issue that we have to be better about helping them translate their experience, right? If you're doing something in Baltimore City, how can that translate more broadly? I think, but also working with the many different places where people get jobs to say, hey, this is also global health, and 3 months, 10 months in Tanzania, you know, there are equivalents to doing that work in the US. So thank you for that reflection.
It's fascinating. If people who studied in Johns Hopkins University struggle to find jobs, then the rest of us can you know. The point is there will always be hindrances, and education is fascinating. There is an expectation, right? In medical schools, when I studied, I was expected to be able to competently diagnose and treat without making mistakes. No one ever told me about, you know, being compassionate. That was not a requirement. And when I was in my residency, actually, I was told to not spend too much time in the ward, admittedly in a very old-fashioned hospital, because people need to respect and fear you as a doctor if they are to listen to you. And that's different now. We don't call our patients, you know, the liver cancer in bed 12 anymore. We realize that that there are more than the sum. But there is, you know, I'm a big advocate of learning what's already been learned. And in education particularly, we are still, and I'm not criticizing, I'm saying generally, there's still a unidirectional transfer of knowledge that is already established as a fact from a teacher to a student. Now, we can caricature that as much as we want, but this is how things still happen, because there is a general requirement for you to be able to give people a degree. You need to establish a few things. But within that, this question has been answered. Paulo Freire, a Brazilian educator, wrote Pedagogy for the Oppressed 55 years ago. And the main element is turn people from objects you act on into subjects with sovereignty, into partners. This applies to the teacher-student relationship in his mind, but it also applies to the global health relation. We still have external, I don't want to say European or American, because it happens, I've done it before, stupidly. I still go and think that I know automatically 3 hours after I landed in a country what's better to do than the people who are there. And that includes the power to spend resources or deny resources. And I've took it in my strides most of my career. And it took people who stood up and told me how wrong I was for me to start examining my position. Now, what I'm saying is not everybody needs to go through 15 years of career before they realize that the mistakes they are making. We can help with that, but it requires what, again, Freire calls critical consciousness. It requires an engagement, a desire to, disassimilate, if I may call it that, to go out of the mainstream as a desired thing rather than as being called a troublemaker because you're not. And this can be either suppressed or promoted by universities as a first step towards people choosing to do it or not, maybe.
Absolutely. I mean, those are very, very fundamental, pieces of advice for us. I think, and just to remark on the fact that our dean launched today's events this morning with an acknowledgement of the lands on which our institutions have been built and the native peoples from whom these lands were taken. And so, I think it is that consciousness of where we are, who we are, and what we are doing that has to permeate our work. Aletta, any last words?
Yes, I want to say that I agree with what Dr. Aloudat was saying. I didn't know that I had a couple of minutes to add to that, but I think for me, it has been actually important over the last, I don't know, decade or so to confront some what I would call the internalized assumption of inferiority. And like, especially when I you know, after I left home and went and did my doctoral studies overseas, and when I look back and when I see or hear how South Africa is talked about, for example, sort of like recognizing that there is capacity in my own home country that you often don't hear about. So I think I have that responsibility to act as an advocate. I think we should not give up on that. But as I mentioned before, it becomes a little bit burdensome because you're trying to balance that with your actually work responsibilities in order to make progress in your own career. But I think recognizing those internalized feelings and working towards changing our attitudes is very important.
Thanks, Aletta. Laura, any summative words that you'd like to add?
No, actually, I think it would completely to echo Aletta and Dr. Aloudat mentioned of absolutely that discomfort. I think that's a space that I've been in the last 3 years since I'm co-founding the working group, but really in the last decade of being in global health, of constantly learning and unlearning and really recognizing what have I internalized, and also how have I been not just complicit, but how have I also been active in perpetuating oppression or perpetuating these harmful practices. So absolutely, the critical reflection and sitting in that discomfort is just something I always advocate for everyone, and just taking that moment to ask yourself, checking in with yourself, but like really ask yourself, what is the intention of the words I'm going to speak or the actions I'm going to take? What is the intention behind it, and what is the purpose? What purpose am I doing this for? Am I just doing it just to do it, or is there a reason behind it? Those would really be kind of my parting words.